I'm a high volume stone surgeon, and so I perform a lot of ureteroscopy and PCNL procedures. And so, similar to what Dr. Kim was speaking about, I do a lot of ureteroscopy cases. And so I think I'm going to talk briefly just about how can we, we're always thinking in the operating room of how can we do things better, faster, in a healthier way for us as the surgeon, ergonomically. And as we think about ureteroscopy, there's, I think, always opportunities to make what we do better, both for ourselves as surgeons and also for our patients and outcomes. I think this is a fun history because I think it's nice to think back of how did ureteroscopy start. And it actually, cystoscopy has been around for hundreds of years. In 1806, the first cystoscopy was documented using a candle as a light source, which is kind of cool to think about. And then it wasn't until the 1900s when the first, I guess technically ureteroscopy was performed using a small camera to dilate the ureter and look inside. And you can see here an illustration of what that used to look like, including the light source. And then really since then, that kind of opened the gates to innovation. The first true rigid scope was designed in the 1960 by Dr. Hopkins. And then in 1964 is sort of the original date that's credited with the first diagnostic ureteroscopy being performed. And it was a 9 French, essentially a camera. It didn't have a working channel. You had forced diuresis, so there's some person just squeezing a bag and pumping fluid in, and there's no channel or anything like that. And really since then we've had an evolution in technology. The first rigid ureteroscope with a working channel in 1979. And then since then we had kind of evolution to more ureteroscopes in 1980. The first flexible ureteroscope with a working channel that actively could deflect came in 1987. We had laser technology in the 90s, and then fast forward to 2006 was the first digital ureteroscope. I remember that in residency. And then in 2015 was the first single-use flexible ureteroscope. And really since then, which is only 9 years ago, we've seen the field grow from one ureteroscope to so many options. And these are just some of the scopes that are now out there, and everyone has sort of some features that are common, some that are unique. And I think, when we think about these in our hospital, in our setting, there's many factors in what drives us to use a scope. Dr. Kim mentioned many of them, some of them, the cost analysis. What's the benefit? How does this enhance what we do? And I think when it comes to me, I'm on the value analysis committee at my hospital, so I'm involved in deciding technologies and how to, when we want to add something or bring something in. I think there's twofold. There's the cost analysis, but then there's also the benefit for the surgeon and the patient. And I think if we want to think about how do we innovate a ureteroscope or upgrade the scopes that we have in our hospital to new technology, what are some of the things we think about? And so I think some of these are common sense and some I think are more nuanced. But generally, this is a nice review that came out a few years ago that looked at how do you evaluate scopes and think about comparing them. And so some of the tools that have been looked at, obviously, is the size of a scope, the sheath diameter. We think smaller is probably, has advantages in passing it up the sheath. Working channels, which allow us to do the work that we need to do, whether that's a laser, irrigation, or basketing. For me, a big one is ergonomics. I have a medium to large hand. Some of my colleagues have smaller hands. How am I going to, if I'm doing 6 or 8 of these cases in a day and you're holding a scope, you want something that's kind of a nice weight. I like a little bit of a weight to it, but not too heavy, not overstretching your thumb or ergonomically taxing your hand. What about the durability or the fatigability? Does the scope last through your case? With single-use scopes, it's less of an issue because when you're done with the case, you don't need it again, but you want to make sure it lasts. I think the optics are something that is becoming more and more common, just having a high-quality picture, but really the resolution of color is something that each processor and the chips that we use all have different algorithms. For me, having that ability to discriminate color, especially if you're looking for cancer or urothelial surveillance, being able to distinguish pink from red, for me is very important. And then finally, I think most important is maneuverability. So that includes a few different things. How can you deflect the scope? But really, for me, treating stones all day, it's really, what is my ability to access the calyces and the stones where they are located? I'm often sent complex stones from the community, so these might be 1 to 2 centimeter stones. They might be in a lower pole, in a difficult area. Another urologist has probably already tried to do ureteroscopy and failed, so they are often sent to me. And this isn't a stone that I can simply basket and move, relocate to another calyx, especially if another urologist has already tried. So for me, really being able to access where I need to go and potentially treating the stones in location is very important. And that includes both deflection, but also flexibility. And also I work with residents, so trying to do these complex maneuvers in a way that a resident can also be taught, for me, is important. So spinning the scope 180 degrees or 360, while that I can do that, I would rather not have to do that all day, and especially if I'm teaching. It just introduces the risk of causing trauma inside the kidney. So these are just some fun, slightly older slides comparing some of the original scopes. And up here you can see these are some of the fiber optic scopes. Just out of curiosity, by a show of hands, how many people are still using fiber optic ureteroscopes in their practice? Okay. And how about digital reusable scopes? Okay, so most people have shifted. And then how many people are using single-use scopes in some form at their practice? Okay. How many are using exclusively single-use? Okay, good. So it's a good mix. In my training, we still had to use the fiber optic scopes, and so when I came out of training, I had a very strong forearm, and I didn't appreciate why until I got to my fellowship and started using digital, and the scopes are significantly lighter, and all the you don't appreciate it until the resident picks up a fiber optic scope and says, "Geez, this is so heavy, I can't even do one case with it." So you can see by weight, the old scopes, fiber optic, were anywhere from 300 grams up to 900 grams, which is almost a kilogram. And I don't have a slide here, but the cameras were 300 to 500 grams as well. So you add all that together, you're looking at almost a kilogram of equipment that you're having to hold for 8 hours in the day. The digital scopes have kind of come down to 400 to 500 grams. You can see on here, this was done in the time when the LithoVue was the first scope, and it was 277 grams, so significant reduction. This table here shows some of the newer single-use scopes, and they're all in the 140 to 200 gram range. So I think ergonomically for surgeon health, this has been a real success story in just helping us be less fatigued. This is an example of one study that I picked it more just because of the different colors and scopes it shows, but there is a variety in how we perceive color and resolution. And interestingly, across the field, we don't have a good way to standardize how we do that. So in America, we joke, if you go into a department store, you want to buy a television, there's 10 or 20 televisions, and they all have different resolutions with different specs and different units, and you can't compare them. And it's kind of similar here. You have to just see what looks good and what doesn't. For those of you who've tried the DYNE scope in the display, for example, it has really crisp color and really good resolution. And we don't really have a way to kind of standardize the metrics on it, but we can talk about it in our perception. For me, the other main thing is deflection. So having a scope that is able to do these kind of deflections for complicated maneuvers and stones, especially in these lower pole areas, can be very challenging. This is a case, you can see this lower pole. I had a patient referred to me who the previous urologist was unable to access the stone in the lower pole. The patient was really they were a very active player in their orchestra. They didn't want a PCNL because they didn't want to have the recovery of no strenuous activities. So they were sent to me to try to do ureteroscopy into that lower pole. And so you can see here, this is with a single-use scope, but that's quite an impressive angle we were able to cannulate. Now, when you're treating a stone down in this angle, sometimes you don't have the luxury of moving it with a basket, and so being able to access it with your fiber is important in these tight angles. And so, let me just see one thing. Yeah, okay. So there's a survey that was put out by Dr. DYNE's group actually this year that surveyed 200 or 300 members of the Endo-Urologic Society about what features do they look for in a scope. And it turns out image quality and lower pole deflection ability were the top two ranking most important features. And so I think that just highlights the same thing we're all feeling in our practices. Interestingly, when they asked about future techniques too, fragment suctioning, ability to irrigate and do suctioning were the most popular sort of concepts people want to have in future iterations of technology. So back to this lower pole deflection ability and how do you access. And I think this is where, a lot of scopes now are very similar in what they can do. And I think the working channel does set apart this scope. Most of our working channels are offset either in the 3 o'clock or the 9 o'clock position. And it's a little hard to see in this picture, but the little square shape is generally the camera on each of these scopes, and the circle is the working channel. And they're offset. And I think conceptually this makes sense. We didn't really have a way to objectify this, but there's these are just 3 videos from 3 cases I did with different scopes. And so you can appreciate that, when you're treating a stone in the left, for example, this patient, there's a lot of respiratory variation, but also the stone is kind of tucked away in the lower left corner of that calyx. So you can see the top of it, and the bottom is kind of fixed, but can't really get to it because I'm maximally torquing my scope, and because of the laser fiber in this case comes in at the 9 o'clock position, I can't really get over there. And because of the torquing, I can't do that maneuver of rotating the scope 180. And so you can see I haven't even started lasering the stone yet because I'm just trying to figure out what I can do with my motion. And you can see nothing's really happening even though I'm moving my wrist a lot. And the stone on the right and then the one in the middle with the working channel coming in from the side, the one in the middle, this stone, ideally, it'd be nice to kind of hit it straight on because there's this tissue that's encroaching from the left. And finally, the stone on the right, you can see I've created a really nice cavity on the right half of the stone because that's where my laser is coming in. And then I'm going to have to try to maneuver to rotate the stone so that I can access it with the fiber. So the way our brains work, I think we naturally, with these technologies, we're programmed to kind of like leaning a little bit with our fibers and angling all of our activities in the direction with which our working channel goes. When I think a more natural way that we just really haven't encountered would be possibly having this central 6 o'clock channel that the DYNE scope has that was alluded to. And so there's this neat study that Dr. Traxler's group did that looked at working channel location and does it have an effect. And they actually created this model where they passed the scope in to calyces, either anterior or posterior on the left or the right half of the kidney. And you can see here in the green is the area they were able to access using their laser. And so they use these 2 scopes, the Flex X2S, which has a working channel in the 9 o'clock position, and the XC has a channel at the 3 o'clock. And basically the take-home is on this left figure in the posterior calyces, you can see on the left half of the screen that the 3 o'clock, which is the XC, the fiber coming in from the 3 o'clock was able to treat the right kidney much better. And likewise, the left kidney was more accessible for its working channel from the 9 o'clock. And then on the right side, these are anterior calyces, and the effect is reversed. But it's still, one side is more suited for each orientation of a scope. So the take-home conclusion from their paper, they say, we believe that the ideal endoscope should be as small as possible, with a very short, undeflectable end tip segment provided with digital technology with different working channel positions in order to guarantee adequate stone or tumor chasing in any situation. So they're advocating that we should have one scope, comes in 2 packages. You can get a working channel on the left or the right, and then based on what side you're going to be working on, you can choose the scope to help you do that. What if you're doing a bilateral stone? You'd hate to open two scopes to achieve that purpose. And so I think that's kind of the ideal scenario, and I think that's where having a channel in the middle, instead of having to choose a side, really can offer an advantage. And just to show a freeze frame from those stones I was treating, imagine if you had a channel in the middle, you can potentially maneuver a little bit more with more flexibility in either direction without having to worry about more of the angulation and the torquing. So I'll leave you there, and we'll continue with Dr. Cho. Thank you very much.